I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. I'm taking the taboos of menopause and perimenopause and bringing light to the dark. No bullshit, no shame. It's time for us to gain a new paradigm in female health, out with the old and in with the new, and I'm bringing fresh perspectives from someone in the arena. I've been practicing women's health for nearly 20 years, and I'm spilling the tea on what it means to live at midlife, knowing that the best is yet to come. I'm sharing my Gen X approach to living through this transition. Sassy, a bit sweary, and always honest. Tactical tips and instantly usable information is my aim. I hope to make you laugh and that you learn something new that helps you embrace the change. Together, we bring power to the peri. Onward to the podcast. Hello, listeners. I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. Did you know that urinary incontinence can be exacerbated by dehydration? What? I know so many women who will, once they start leaking urine, will stop drinking water because they think that's going to prevent them from leaking urine. And so we walk around chronically dehydrated. And I had no idea that that actually made it worse. But thank goodness I have the amazing Kim Vopni on the show today, the Vagina Coach herself, coming to share nuggets of wisdom on the pelvic floor fitness. She is a women's health coach. She is the creator of the Buff Muff Method and the Between Two Lips podcast. And man, we had a juicy conversation. I loved every minute of this. I learned a ton. Kim educated me on the different things that can go wrong with pelvic floor. We talked about urinary incontinence, pelvic pain, incontinence, fecal material, prolapse. All of these things can happen and they feel so shameful. Like who can we possibly discuss this with? Of course you want to talk to your doctor about it, but I really feel strongly that this is changing. And with the explosion of information around menopause, we're now seeing an interest in pelvic floor health. And of course, there are countries around the world that have much better awareness of this, that actually have supports for women, not just for menopause, but throughout the whole lifetime around pelvic floor health. Kim and I talk about that. Kim told me that 95.1% of women with low back pain have pelvic floor dysfunction. What? Scrape me off the floor. Where was that information in my education, in my professional education? I can tell you it was absent. And I don't think this information's all that new. Yes, I was in school 25 years ago, but hey, it's not that. It's been around. So now we're talking about it. We're talking about how low estrogen affects the pelvic floor health, affects the muscle health, not just whether or not you have painful intercourse, but it's about what's happening with those actual muscles. Okay, so I'm sure if you have spent any time on Instagram and you've ever talked about menopause around your phone, you've seen Kim's Buff Muff Method exercises. That's her with the leggings that look like skeleton and muscle. She is out there. She is out there and we can see it and it's fantastic. I am so grateful for it because I know I have learned a ton from Kim and I know many of my patients have as well. So I hope that's true for you too. Let me introduce my awesome guest. Kim Vopni is a certified fitness professional and menopause support practitioner known as the Vagina Coach. She became passionate about spreading information on pelvic health after the birth of her first child over 20 years ago. Kim is a sought-after speaker, a women's health educator, and the author of 3 books. She began her work with the prenatal and postpartum population, where she founded her own business and co-founded a second company called Bellies Inc. She now works primarily with women in the menopause and postmenopause phases of life. Doctors and physical therapists are always referring her clients their clients to her Buff Muff Method as the go-to pelvic health resource that allows women from around the world to find support through workouts, challenges, and group coaching. Kim also certifies other fitness and movement professionals to work with women with core and pelvic floor challenges through her Buff Muff Method practitioner certification. You can find her online through her podcast, Between Two Lips, her website at www.vaginacoach.com, and on social media at Vagina Coach. I think this will be a very useful conversation for a lot of you, and I hope you get as much out of it as I did. Thank you for listening. Thank you for all the years of support, coming to hear what I have to say with these amazing guests that just humble me every day and make me feel like this is it. This is the cutting edge information. You heard it here first. Thanks again for listening. Without further ado, here's my conversation with Kim Vopni. The AG1 you've all heard me talking about for so long just went through a major upgrade. AG1's next gen is here. It's the same single scoop once a day, but now it's clinically backed and formulated with more upgraded vitamins, minerals, and probiotics. The new next-gen formula offers a more advanced, clinically backed formula that fills common nutrient gaps and supports gut health, all in the same easy, once-a-day ritual. AG1 has been a game changer for my mornings. It sets the tone for my day, helps me feel my best, and like I'm taking care of my nutrient needs in one step. AG1's Next Gen includes 5 clinically studied probiotics and additional vitamins and minerals to support whole body health. Now clinically backed with an advanced formula, this is the perfect time to try AG1 if you haven't yet. I've been drinking AG1 daily for 6 years now, and I'm so happy to be partnering with them. Subscribe today and try the next gen of AG1. If you use my link, you'll also get a free bottle of AG D3K2, that's vitamin D3K2, an AG1 welcome kit, and 5 of the upgraded AG1 travel packs with your first order. So make sure to check out drinkag1.com. That's drinkag1.com/Fiona Lovely to get started with AG1's Next Gen and notice the benefits for yourself. That's drinkag1.com/Fiona Lovely. I'm Dr. Fiona Lovely. Welcome to the Not Your Mother's Menopause podcast. And I'm so excited to have a friend and a fellow Canadian with me today, Kim Vopni, the Vagina Coach. Welcome to the show.
Thank you. Excited to be here with you.
I am so excited to be here with you too. So here's something you don't know. I have been fangirling your Instagram page for a very long time, years. I think COVID years is kind of where it came online for me. And I remember seeing your puppet that's over your left shoulder, your pussy puppet over your left shoulder. Does it have a name, by the way?
I don't name her. No, I don't. I should, but no, I've never named her. She's just my bull. I used to call it my remember Little Miss Muffet? So I used to call her my Muffet because it's a muff puppet, but
I think that's fantastic. Yeah, anyways, you were the first one I saw with a muff puppet, Little Miss Muffet puppet. I got to remember I'm recording a show here, Kim. Anyways, we're going to have some fun today because we've got such a great topic to discuss. And of course, you and I know each other. So those are always I think the most fun conversations on the show. So tell me, how did you find yourself the Vagina Coach?
Yeah, well, I was sitting on my Muffet. No,
eating your curds away.
Eating my curds away. I was afraid of childbirth was really how it started. And then that sort of planted a seed. I saw a childbirth video in 6th grade and I thought, no, thanks. I'm not interested in that. But I still went home and looked at my mom and all the women in my life differently. But I grew up thinking, I remember even having a sticker album and I had little collages in there. And one of the collages I had cut out of a magazine said, I do not want a baby. And that was me. Everybody knew that I wasn't going to have kids. And then anyway, fast forward, decided I did want to start a family. I had watched my sister-in-law give birth, and that was sort of a bit of a turning point for me because it's where I saw birth done differently than that grade childbirth video and anything I'd seen in the media. And anyway, I was asking my midwives, my mom had episiotomies. She had to have surgery for bladder incontinence. She had chronic back pain. Like, what can I do to avoid these things? And tearing was a big one for me. And they said, well, I've heard of this thing called the Epino, which is a biofeedback device. Epino stands for no episiotomy. So I looked into this, made sense to me as a fitness professional, the idea of preparing for your physical event. Like, we prepare for marathons, we prepare for climbing a mountain, we prepare for a triathlon. Nobody talks about preparing for birth, yet they say that birth is like running a marathon. I argue it's running like 5 or 6 marathons. So I thought, well, we really should be preparing for this. And this device was stretching and strengthening and training muscles. So I said, of course, this makes sense to me. So I purchased one. I had a great experience, didn't have any tearing. And I thought, well, why doesn't everybody use one of these? And I contacted the company and said, could I be a distributor here in Canada? And I didn't intend for it to be a business. I thought I would just sell it to friends and through my midwives. And so that's how it started a little over 20 years ago. And I was working with pregnant women, trying to get them aware of the pelvic floor before they gave birth. So I created a program called Prepare to Push, and I was giving, pelvic floor education, birth positioning, all these things with the intention of reducing tearing, reducing pelvic floor dysfunction afterwards. And also in that process was learning that people don't think about recovery here in North America. We sprint back to the gym as fast as possible. We have to look not pregnant as fast as possible, which I think is also contributing to the pelvic floor dysfunction side of things. So originally, I was working with pregnant women. I was a personal trainer. I trained as a doula. I was known as the fitness doula. Then started a second business, Bellies Inc. I was 2 other women and myself, and we manufactured our own postpartum wrap, and we were wanting to optimize postpartum recoveries and bring in traditional practices from elsewhere around the world and get it here a little bit more mainstream. So that was that. Then I started to go through my own perimenopause journey. And I started to work more with that population and menopause, and fitness doula didn't resonate quite so much. And about 8 years or so ago, I was speaking to a group of women the organization was called the Mompreneur organization at the time. It's renamed now, but I was speaking at their national conference, and all of the speakers were some sort of a business coach. And I came up on stage and I joked, now you have a vagina coach for your business. And it was a joke. And it was that, you lead with something funny. And it was like, that's it. I have to say this really uncomfortable word that nobody likes to talk about. We always whisper it. And ultimately it kind of sums up what I'm doing. It's covering all the spans of life stages that we go through with our vulvas and our vaginas. And that's how it came to be.
Oh, I love that. Well, thank God you're talking about it, because you're right. It was whispered for so long, and now we're saying the word, but we're also not using it correctly, because the outside anatomy is the vulva, right? The vagina itself is the inside. But at least we're not whispering it anymore, right?
Yep. Yeah.
At least
Well, it was funny. I needed to say for a long time, I would have posts taken down. I couldn't name my page Vagina Coach. And I remember, instead of saying the word vagina, I would say the tube that attaches to the cervix coach, or, it was just ridiculous. The hoops you would have to jump through because it was an inappropriate term.
Yes. Wow. It's crazy. I remember you telling me once that it was you used the pink purse emoji a whole lot.
I still use the pink purse.
Okay, good. Well, I never thought of that. That's one of those sections of the emojis I'm looking at. I'm going, what do people use this for? I don't know. No, now I understand. It's like the eggplant. Nobody used the eggplant. I still think that's a terrible misrepresentation of the average anatomy of a male, but yes, whatever. You would just say really an eggplant, you guys wish. Anyways, okay. So pelvic floor health. Let's talk about that. Now, I don't remember ever hearing anybody talk about pelvic floor when I was younger and technically in my reproductive years. I literally remember nobody ever even mentioning it. So when did that turn around? When did you start to see people talking about it more frequently? Are we there yet?
We are definitely there. Yeah. I wouldn't say we're fully there, but we have made huge progress. So I would say in the last 3 to 5 years, I have people now saying, without me saying to them, go see a pelvic floor physical therapist, I have people coming to me say, my pelvic floor physio or when I saw my PT the last time. So there is the awareness has definitely increased. There is way more conversation around it. The explosion of the conversation around menopause has also indirectly supported a conversation around pelvic health because of genitourinary syndrome of menopause. Just over 20 years ago was when I initially started, didn't even know the term pelvic floor. I just knew prevent tearing and I knew perineum. Those were the terms that I knew at the time. I'd never heard of pelvic organ prolapse. I didn't know the different forms of incontinence. I didn't know about pelvic pain. I didn't know the correlation with back pain. Like there was a lot. I just kind of, my interpretation from growing up was if I don't tear or have an episiotomy like my mom, then I won't have incontinence. That was my limited belief at the time. So it wasn't until even when I started using the Epino, I can't even remember the literature if it actually used the terminology pelvic floor. It was more, it said perineum. I remember that. I'd have to look back in that literature and see, but it was around the time when I started, it was more after I'd given birth where I started to know this term pelvic floor. And so I would say we are definitely pretty close. We have some work to do. It's not still standard of care. It's not talked about by everybody. There's still, I hear every day from people who've never heard of the term pelvic floor physiotherapist before. But the awareness is definitely more than it used to be. And in terms of what pelvic floor health is or pelvic health, growing up, like I said, I'd never heard it until it was, until I looked into this device. So had I not even looked into this device, I don't think I would have been, my midwives didn't tell me that. I've never had in a PAP exam, never been told that, nothing. So I think we should be teaching kids, when we are teaching them about bodies and sexual health and menstrual cycles and all the things, why are we not talking about this really important group of muscles called the pelvic floor, knowing that the majority of women will become pregnant at some point in their life? That is a very well-established major risk factor for pelvic floor dysfunction. We have menstrual cycles, we have hormonal fluctuations. Anybody who's reaching midlife, we're all going to go through menopause. You don't have to have been pregnant to experience pelvic floor dysfunction. And what we're seeing is things are happening younger than they did before. And so we need to look at why is that, but also why are we not talking about it earlier? And giving people the tools and the education and the awareness so they know that there's no shame, that they're not alone, that there are professionals that can help them. Suffering is not something that you have to accept just because, that's just how it is, or because you're a woman, or because you're getting older, or whatever it is.
Or all the things. Yeah. I remember hearing the words pelvic floor when I was in professional school. Obviously, musculoskeletal health is my expertise, or at least my my professional expertise. And I remember hearing about it, but it was always in the context of the neurology, which is S2 through 4, keeps poo off the floor, right?
Floor, yep.
And so, but there was never anything more about that, and that was 25 years ago. So let's hope that things are much better. But now that I work in a clinic with a pelvic floor physio, she and I can work some really interesting angles together. That sounds like that was code for something it really isn't. But what I have always said to her, and with the patient's consent, is let me know what's happening on the inside so I can watch for what it looks like on the outside. Because
Totally.
here I am working a woman's SI joint pain, gluteal pain, the gluteal tendinopathies that we're seeing as part of the musculoskeletal syndrome of menopause, lumbar spine pain. These things are all very, very common for women. But to understand it better, because I can get the information of what's happening on the inside, I think is quite revolutionary to how we treat women.
1,000%.
Yes, exactly.
1,000%.
And it should be part of, standard of care. And we got to walk.
There was a research study by Dr. Sinead Dufour, who's a pelvic floor PT out of Burlington, Ontario, who mainly research now. I don't think she even does any in-person practice anymore, but this study was looking at low back pain and pelvic floor dysfunction. And so it was women coming in presenting with low back pain. And in that particular study, and many other studies have similar statistics, 95.3% of women who have low back pain have some form of pelvic floor dysfunction. And a lot of them will be seeing a chiropractor, massage therapist, acupuncture, which can absolutely all play a role. But so often the missing link is the pelvis. And what you have in your office is how I wish all health care was designed in that collaborative fashion, because it's just so incredible for the learning and the awareness that you develop as a clinician, but also that patient who doesn't have to be jumping around and searching. And it's just everybody is working on the behalf of that person. And I think it's incredible. Another point I want to make is you talked about, you learned it in your training. I'm a personal trainer. We learn about muscles in the body, and we learned about every single muscle except the pelvic floor. And when we learn about core and core exercise, the pelvic floor is the foundation of the core. And never in any, to my knowledge, still no fundamental personal training certification includes the pelvic floor. And it 1,000,000,000% needs to be in there.
Yes, absolutely. Oh my, there's so many things to pick apart here, Kim. I think I'm going to be hitting you up for that paper later, the name of that physio, because I want to take a look at that myself. But this is women's healthcare by women for women, and that's what we've had to do in order to get that level of collaborative care. And it's fascinating to see, especially if it's a patient that I've treated for years and years and years. I'm like, why can we only get you so far? What is happening here? And then I send her to see the pelvic floor physio, and I hear what's happening on the inside. And I go, oh, that's why we can only get you so far. But as you said, for those of us that are somatic workers, for most of us, we didn't get any of this in our training at all. Just, as I said, I hope it's better now, but it just wasn't part of the training. So as we learn about musculoskeletal syndrome of menopause, the genitourinary syndrome of menopause, we start to plug these things in together, then I think we'll see greater and greater levels of care. And I know just recently there were the practitioners in the clinic that I work with were having a discussion about, we need a personal trainer locally who actually can take care of women's health at midlife. That is such a specific thing.
Yeah.
And, how do we find that person, Kim? Can you help us understand how we can find a person that will understand? Because a woman's body at 40 and 50 is profoundly different than a woman's body at 18 or 30 or 35.
Yeah. I have a certification course, and it was created in 2013 when I had my company Bellies Inc. with one was a pelvic floor PT. My other partner was a personal trainer like myself. So we were two of us working in the fitness industry, recognizing this void. We decided to create this certification course. It has evolved tremendously, and it will continue to keep evolving with new research and new awareness and what have you. At the time, we were very focused on prenatal and postpartum, and then have expanded now to cover all life stages. And I tell you that because initially we used to have a directory, and now I'm in the middle, probably in June, it'll be the relaunch of the new course. And we will have a directory again of people who are certified in, well, my method is called the Buff Muff Method. And it really, it's a comprehensive, it's not just pelvic floor, although that is a big part of what is talked about. It's sort of a women's health certification, women's health and fitness certification, that gives people the awareness of the differences in the female anatomy, the different stages of life, the menstrual cycle, the hormone changes of menopause, the tissue changes, the different pelvic floor dysfunctions, and how we, within our scope, so we being fitness professionals don't do any internal evaluation. So how within our scope can we screen for these conditions, collaborate with the pelvic floor PTs, so have a relationship very much like you, where we would have this referral form. People would come to see us as a personal trainer. I fill out the form. I say, take this to your pelvic floor PT. Here's the list of who I recommend. That PT then confirms what our suspicions or, thoughts are. They come back. We work together on creating an exercise plan, and that person feels very supported, from the inside out, literally. And so stay tuned. My director will be back up. But I always say start first with a pelvic floor physiotherapist. If you're in Canada, they're called physiotherapists. If you're in the United States, it would be a physical therapist. Many parts of Europe and Australia and New Zealand will also use physiotherapy as well. So somebody who is trained as a pelvic floor PT I always recommend that as the first step. And now most of those PTs do work with personal trainers or kinesiologists who have some level of training in similar to myself, where you've done some education with regards to menopause, you've done some education as it pertains to the pelvic floor. But there is currently no robust directories of where to find those people from a fitness perspective yet.
Yes. What I say to my patients is ask your pelvic floor physio for sure, then ask your girlfriends.
Yeah.
And if you've got a 21-year-old that's telling you to do heavy deadlifts and you're a 50-year-old woman, you're probably going to have some difficulties and you should ask somebody else.
Yeah. 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 And the majority of personal trainers, I shouldn't say the majority, I actually don't know the breakdown on this, but there are a lot of male personal trainers and the majority of their caseload is women. And so I've been teaching this course for 12 years and I can count, like literally we have had probably no more than 10 men come to the course because they look at this, oh, I don't need to know that. And like if you definitely need to know it,
Yeah,
because the majority of your client base is female. You need to absolutely understand the menstrual cycle. Has they been pregnant before? Would you support them through pregnancy if they become pregnant? Like all of these things. So yeah, it's my hope that more men will start taking the certification as well.
Well, and especially when we're in an era now where for good menopause practice, we want to be building muscle. We want to be focused on
1000%.
You know, we need practitioners who know what that looks like for women in our age group and women who are older and the youngsters that are coming up now, the millennials that are coming up, that things are changing for, and they're going all of a sudden, why am I having all these symptoms? Oh, welcome to perimenopause, babe.
Yeah.
Strap in. It's going to be a while. Like,
Yeah.
get your people around you.
Yeah.
So I want to go ahead. Sorry.
I was just going to say on that with so the explosion, first of all, of menopause, and now there's these little subcategories, one of which is now bone health. And the messages that people are hearing on social media is we have to lift heavy and we need to do impact or loading and jumping, which yes, those are our stimulus for building bone. However, there is a 46% of women, almost 1 in 2, who stop exercising because of their pelvic floor. So either they are self-removing themselves because they are symptomatic or they think it's going to make things worse, or they have sometimes even been told by their care provider, you can't jump, you can't lift anything over X pounds if you have a prolapse or if you have incontinence or pelvic floor dysfunction. So they're looking at those messages saying, well, I should be doing that, but how do I do that? And I'm trying to, like, as you say, we want the people who are trained to help you get it. That's a progression to get there. We don't just all of a sudden start lifting heavy one day and pick up a really heavy weight and do 4 sets of 4. That's not where we start. Yeah. And we also need to have the pelvic floor resilient enough and strong enough and capable to manage those loads. Mm-hmm. And so many, especially people, if they have been sedentary or if they have been holding back because of their pelvic floor, and then they go from 0 to 60, then we have more struggles. So again, more reason why this needs to be, we need to be taught this much earlier in life.
Absolutely, we do. So when as the chiropractor, when I hear the lift heavy message, I'm like, hold on a second. Most women have been not doing physical activity for a long period of time. And so what happens is you told to lift heavy, you go in and you do that and you injure yourself.
Yeah.
Right. So you got to have form proper, but I never really considered until you just said what you did about the importance of pelvic floor. So in a way, that is okay. So what does that look like? Like, is that a woman lifting a barbell and she wets herself? Is that what you're talking about? Let's be real clear on what we're talking about here.
Yeah, there's a lot of people who, and I don't want to throw CrossFit under the bus completely, but CrossFit has become, even years ago, it was very popular, high intensity exercise. And a lot of women in midlife who are now putting weight on or thinking, oh, I need more exercise. I need more intense exercise. So they are pursuing these. And there is so much benefit to exercise. There's benefit to CrossFit. I don't want to take away from how valuable that can be. However, very intense exercise, we have research to show, especially, power lifters, Olympic lifters, CrossFit will experience leakage, Box jumps is a big one. Deadlifts is a big one. Running is a big one. So leaking urine when you're not sitting on a toilet is called incontinence. The stress urinary incontinence is where there's some sort of an exertion. So a heavy lift, a cough, a sneeze, even standing up from a chair is an increase in intra-abdominal pressure that if we don't have the capacity in the pelvic floor to manage, like to meet that pressure and hold it back, so to speak, then we're going to leak a little bit of urine. So knowing that, and there is like way back when I was starting this, there was zero research on sport, on fitness, on anything to do with the pelvic floor. There was nothing. And now, thankfully, there's a lot more that we can pull from and draw from. So we know that higher intensity exercise can be problematic for the pelvic floor. Now, that doesn't mean, in my opinion, and there hasn't been any research to look at this yet, but what has been shown in many of those research articles is that the knowledge of the pelvic floor is little to none. So had we earlier on been told of pelvic floor muscle training, we see a pelvic floor physical therapist once a year, we know how to incorporate and how to lift properly and how not to create these major increases in intra-abdominal pressure that eventually start to overwhelm the pelvic floor, I think it would change. I think it would change. But currently, limited knowledge of pelvic floor, or none for some people. I want to lift heavy. I'm going to CrossFit is awesome. I need to increase intensity because I'm gaining weight. That kind of couples into this perfect storm that now people are like, I lifted one day and all of a sudden I felt this pop sensation and now I've got this bulge between my legs. Or there was even a video that this was probably 8 to 10 years ago. It was a video that was filming at a CrossFit Games competition. And they were highlighting and filming women who had just lost control of their bladder on the competition floor. They were wiping it up. They were laughing. That's just what happens. That's what it takes to be the fittest woman in the world.
Oh no.
They had an OB-GYN in the audience who was saying, yeah, well, that's just what happens. And all of us in the pelvic health world were cringing. And that's what gave CrossFit such a bad reputation.
Terrible.
And I think we have to look at that and say, that's not normal. It's the body is you're reaching a point where the pelvic floor is just like, okay, you've been ignoring symptoms along the way. I just can't do it anymore. And it completely goes like that. There's something wrong there. And I don't think that we should be glorifying that and celebrating that.
Agreed.
And is that really truly a sign of being the fittest person if you don't have bladder control?
I think if anything that I've learned working in clinic with a pelvic floor physio is just how much pelvic floor health is an indicator and a predictor of overall health for women as we get older. So we can't ignore these things. So
Yeah.
Kim, what does that look like? Describe when the pelvic floor is becoming dysfunctional or is having troubles doing what it's supposed to do. What are those symptoms that you just mentioned? Please let's break it down so it's really clear for people.
So leaking, as I mentioned, with exertion is stress urinary incontinence. So laugh, cough, sneeze, jump, push a heavy door open, stand up from a chair, lying down on the ground, getting up off of it. There is an increase in intra-abdominal pressure that is greater than what the pelvic floor can withstand, and a little bit of urine will leak out. Then we have urgency or urge incontinence, and that would be where maybe people don't leak with a cough or a sneeze, but when they come home and they put the key in the front door, all of a sudden they get this like, they've got to like race to the bathroom. They're crossing their legs. They're pushing everybody out of the way. And there's this alarm bell is going off. And sometimes there might be a bit of leakage. Sometimes there might be a complete release of the bladder. And that is very life altering if somebody's worried that they're going to have a complete release of their bladder. So that's urgency or urge incontinence. You can have mixed, which would be a combination of the two. You can have anal incontinence, so gas or stool, also urgency with anal incontinence as well. Then we have, there's a true definition of overactive bladder, a medical diagnosis. And there are certain people whose detrusor muscle, the bladder muscle, reacts inappropriately, very strongly, at inappropriate times. And there is testing you go through to determine if that's truly what your problem is. But a lot of people will go usually after a long period of time of suffering, they finally go to get some help. They say, I feel like I need to go to the bathroom all the time and have these really strong urges. And the doctor will give them overactive bladder medication without really the root cause investigation. So I just want to differentiate. Some people they diagnose themselves as having an overactive bladder, whereas there is a medical diagnosis of that, but there is some testing involved that you would need to get there. Some people also say, I have a small bladder. A lot of doctors will tell you there really is not, like, very, very rarely would there ever truly be somebody who has a small bladder. So the people who feel like they're going, like, this urinary frequency as well. And often that is, we can go into the reasons behind it, but that is often perpetuated with low estrogen, tight muscles, and behaviors that people are doing. Then we have the prolapse category. So this would be where the bladder, the uterus, and or the rectum, they shift out of their proper anatomical position and they bulge into or descend into the vagina. Early stage prolapse is often asymptomatic, but symptoms don't necessarily indicate severity. So an advanced stage of prolapse would be where there would be a visible bulge at or outside the opening of the vagina. Some people can have, that would be like a stage 3, stage 4. Some people can have stage 3 and have 0 symptoms. Some people could have a stage 1 and be crazy symptomatic. So symptoms aren't indicating severity or type. And this is the diagnosis I find that sidelines people the most. It's the one that people feel the most vulnerable with. It's the one that people feel most afraid about. It's the one that is the most bothersome from a symptom perspective, and really kind of starts to, they become very reclusive. They stop participating in many activities with life. And hysterectomy, I just want to point out, in the United States, 600,000 are performed every year. And 9 out of 10 of those are for benign conditions: prolapse, heavy bleeding, and fibroids. And hysterectomies increase the risk of incontinence and prolapse, but nobody is counseled on that. And so many people come to me, I had a hysterectomy however many years ago, now I'm dealing with this. And I, again, think if we were given the information, if we knew about pelvic floor muscle training, pelvic floor physio, this really could change. The final category would be pelvic pain. That is, and there's a bunch of different pain side of things. It could be pain in the vulva. It could be pain in the vestibule of the opening. It could be pain with insertion, could be pubic joint pain, could be tailbone pain, could be like there's painful sex. And is it painful sex because of low estrogen? Is it painful sex because there's tight muscles? Is it because there's an organ in the way? Like there's lots of nuance there under that pain category.
Mm-hmm. Yeah. And, I want to say something about that. You've just said something that I think is, I've seen this come up in clinic over and over again, is when women talk to me about, this is just a Kegel problem.
Yeah.
And I'm like, oh yeah, no. This is far more complex than that. And I think we have a concern of laxity that I think is part of the overall sort of community discussions about how women's bodies are no longer pleasing to men at a certain age and at a certain stage in a woman's life, and how that laxity of the vagina is part of it, to which there is so much horse shit in that camp that I want us to talk about that, because I have said to women over and over again, it's far more likely that the pain you're having during intercourse is because of tight muscles, babe, not the other way around. But that
1,000%.
thing does not get discussed. So please, let's talk about that.
Yeah. Yeah. We have a belief, or maybe we think there's an expectation that we need a tight vagina, and tightness, tight does not equal strong. Yet we have this interpretation, and we might feel laxity. We might have a decrease in sensation, and it's hard for people to understand that it can sometimes be because the muscles are tight. And when we think, well, if I'm leaking urine, how could my muscles be tight? If my organs are shifting and they're dropping, how could my muscles be too tight? And it doesn't seem rational. But a tight muscle doesn't have the blood flow and circulation that we need. It doesn't have the reaction time that we need. So if we laugh, cough, sneeze, jump, we need the pelvic floor muscles to react quickly. We need it to meet the force of the task or whatever it is that we're doing. And if we have a short, tight muscle, it's used up part of its range of motion, its ability to generate power already, and it will also be fatigued because it's been in that short, tight state. So kind of like, I'm sitting here scrunching up my shoulders. If I keep my shoulders close to my ears all day long, if I did that indefinitely, that muscle group will adapt to being shorter. It will be very achy. It will be very tired. It will probably have some trigger points in there. And for me to let that go will become increasingly hard. And if I needed to, for whatever reason, jack my shoulder up even a little bit higher, there's not much more room to go. And I'm probably going to be delayed in that response because I'm tired and I'm fatigued. And the same thing is happening in the pelvic floor. So a lot of the reasons why people are leaking, a lot of the reasons why people are experiencing prolapse, a lot of the reasons why people experience pain is from muscles that can't react, can't generate power, react at the right time with the right amount of force. Now, that is nowhere near the only reason, but it is significant. And people who have, fears of urgency, fears of leaking during sex, fear of will my partner feel or see my prolapse, there is an unconscious guarding that happens in the pelvic floor as well. So some people are like, well, how did my pelvic floor get tight? And sometimes it's posture, sometimes it's footwear, sometimes it's trauma, sometimes, right?
It's the patriarchy. Never mind. Let's go there.
Yes.
Say it.
Yeah.
But that's trauma, right?
Yep. 1,000%. And so every single time, so I do coaching calls with my group. I get questions on Instagram, like, how do I know because I talk about tightness all the time. How do I know if my pelvic floor is tight? And if I list off the symptoms, they're like, but what, how did that doesn't make sense. And I say, go see your pelvic floor PT. That's your best way to understand if what the status is of your pelvic floor. But we have to also let go of these assumptions that tight is the goal. Tight is going to be better. Tight is somehow more pleasurable. If we are tight, we think it's better for our partner. It could prohibit the partner from feeling anything. And even if it's in sort of sex inserting anything, it inhibits our blood flow and circulation. So we need to, in a lot of things in life, we need to let the shit go. We need to let go and relax and release and breathe. And on that point, though, I also want to say is people are often told if they have a tight pelvic floor, if they either know they do or they've been told they do, they are often then told not to do Kegels, which I agree, that's not where we want to start. But tight is weak. Tight muscles are not strong muscles. And we need to work on lengthening. We need to understand the contributing factors to why that shortening and tightening and gripping is happening, unravel that. But we also need to take that muscle through an excursion, through a range of motion, maybe not 10 sets of 10-second holds. No, but we still need to do some pelvic floor activation so that the muscles know what it feels like to let go and what it feels like to be contracted. There was a cool piece of research with a group of patients who were dealing with vulvodynia, which is a pain syndrome, and asked to do a max voluntary contraction, which is usually like, no, don't contract. But they were like, lift, squeeze, do the biggest Kegel you've ever done. And that elicited a greater relaxation response after. So not to say that I think everybody should be training that way, but we don't want to stay 100% on the side of no Kegels or yes Kegels. It's a nuanced approach based on the person.
Protein and healthy muscle are the organ of longevity. Do you struggle to put on muscle, lose weight, or get enough protein each day? It's a common concern, but there's help. I prefer Kion Aminos to get my daily essential amino acids. Kion Aminos ensures you're getting the essential amino acids from protein your body needs to rebuild muscle, recovery, keep energetic, and be strong. Kion Aminos is a clean source, transparent formula that gets mixed into water and tastes good. It's suitable for all diets, is gluten-free and dairy-free. It helps me feel full and hydrated and ready to go. I feel strong and I recover from activity quicker when my protein tank is full. Would you like to get better protein intake and supplement with Kion aminos? Please go to getkion.com/lovely, where Kion is offering 20% off for listeners of the show. There's a risk-free 60-day money-back guarantee. That's getkion.com/lovely. And I'll drop the link in the show notes. Thanks, Kion. Hey guys, Dr. Lovely here again. Sorry to butt in while you're listening to this episode. But in case you don't know, I send out an awesome newsletter every 2 weeks. It's called Fiona's Friday Favorites, and I'm getting lots of great feedback about it. I pack it full of the latest and greatest in menopause and perimenopause information, whether it's research or treatment options or my favorite supplement or my favorite yoga pose or recipe or book or podcast of that 2-week period. People are loving it. So go to drlovely.com. That's drlovely.com. And right at the top where it says shift here, enter your name and your email address, and we'll be sure to add you to the list of Fiona's Friday favorites. Thanks for listening.
The individual.
Those are all things. It's like a neuro retraining, ultimately, is what you're doing with the next contraction. Because we have to pay attention to the nervous system if we are talking about the pelvic floor.
Yep.
You know, one of my favorite things I've learned about the pelvic floor was that it is connected intrinsically to the diaphragm and the tongue.
Yeah.
And I think women, when they become aware of that, we can feel that. I know I can. And when I first became aware of that little tidbit of knowledge, I thought, I wonder what it feels like to relax your tongue. It is way harder than you think. And I think this is actually where, you know, some of all of these things can get tied together, of course. And then we have the breathing issues that go along with the tight diaphragm. And, you know, who's talking about it? I guess you and I are here, and the pelvic floor physios are. But it's new information for a lot of women. A lot of practitioners.
Yeah, it is. And yeah, the power of the breath is when people come in, and that's one of the first things, actually, the first things I talk about are hydration and poop. Those have to be addressed first. But then when we get into the exercise, I teach something called the core breath. And, you know, most people have heard of a Kegel, but the interpretation of what a Kegel is squeeze. And we have evidence to show that the majority of women are doing Kegels incorrectly, either squeezing their inner thighs, squeezing their glutes, bearing down. And so that when I am teaching them this breath and identifying this relationship between the diaphragm and the pelvic floor, that is the hardest part for people to grasp, because like on the note of people doing it incorrectly, many people think that when they engage the pelvic floor is like they're inhaling and they're sort of drawing up, and then they exhale and relax. Because in yoga, whenever we're relaxing, we're like, sigh. And we think that that's when we let things go. Physiologically in the body, though, when we take a breath in, the diaphragm, which is, as you just said as well, is intimately related and connected with the pelvic floor. So when when we're taking a breath in, the diaphragm is essentially kind of widening and flattening, drawing air into the body. And what should be happening underneath is the belly should be expanding and the pelvic floor should be lengthening. So physiologically, the inhales are where the pelvic floor lengthens, and the exhales are where the pelvic floor contracts and lifts. And so many people have been practicing Kegels, inhaling and sort of sucking up and often squeezing and clenching their glutes, and then they relax. So that is that mind-body connection that they need to retrain. And it can sometimes take a week or two for people to to grasp it. And then once they do, then we're going to layer it into some movement as well and progress beyond just a static hold. But it's such an important part. The breath is so important for nervous system regulation, for optimizing that relationship there. It's huge.
And I had that very experience with my own, where she actually walked me through that exercise with feeling what my pelvic floor was doing while I was breathing. She said, "Okay, this is what you want to do. No, this is when you do the relaxation." And it's not at all what we think. And this is the power of the pelvic floor physio coming in and saying, "Here,
Thousand
this is what
percent.
it should feel like." Absolutely. It's a very interesting experience. Okay, hysterectomy. Let's come back to that. Number two most performed surgery in the United States, hysterectomies, cesarean sections, number one. So this is an industry. We have to just acknowledge that first and foremost. And did you say 9 out of 10 or 8 out of 10 are benign
9
conditions?
out of 10.
That's bananas. Okay.
Yep.
So then the question I have is, isn't surgery the fix for pelvic floor dysfunction?
That's what women are led to believe, and that's what they are offered. And I want to say that there is no shame in surgery, and surgery can sometimes be an incredible option for incontinence, for prolapse. Sometimes people need a hysterectomy. However, what is not communicated and what my message is, we need, if surgery is indicated, if surgery is chosen sometimes or needed, there needs to be a prehab, there needs to be rehab. And I argue it increases our need for pelvic floor exercise after surgery. Doesn't, so many people are told, well, I fixed the problem. You don't need pelvic floor muscle training anymore. And I argue exactly the opposite to that. So yes, there are some times where all the exercise in the world, all the posture, all the breath, all the lifestyle factors is not going to change your situation. And if the symptoms are interfering with the quality of your life, then surgery is absolutely something that you can consider. But I want to highlight all of the options and opportunities we have to
Please.
address these ahead of time that could potentially take away that need for surgery. I myself have had a surgery. I had a rectocele repair. I'm not saying people should do this. I lived with it for 9 years. I don't think you need to live with it for 9 years, but that was a whole different story. But I was, I'm working in pelvic health. I felt like a hypocrite. I was, kept thinking there's got to be something I'm missing here. But at the end of the day, there are certain times where that is what you need. There has been a disruption to the anatomy that is beyond repair from exercise or posture or avoiding constipation or all those things. What we can do ahead of time. So as I said already, pelvic floor PT. I argue see one once a year, even if you have no symptoms. You might remember this because you're in Canada. I haven't heard a lot of people say this in the States. And actually just the other day I saw it on Instagram. Do you remember a dentist coming into your grade school class and giving you the little package of pink pills that we chew that would highlight, and plaque on our teeth?
Yep.
And we, that was very compelling. And like, oh my gosh, look at how much plaque I have, and we need to brush and we need to floss. And so we're like, okay, we're brushing, we're flossing, and we will come and see you once or twice a year for the rest of our life. And we will go to our dentist that once or twice a year, even if we have we don't chew a pink pill, we don't have pain, we don't have bleeding gums, we just go because we're supposed to. And if we had that same PR for the pelvic floor earlier on in life, start seeing a pelvic floor PT once you become sexually active, and you see them once a year for the rest of your life, I literally think it would change the world. So that's number one. Next, there are things like pessaries. So pessaries are kind of like, I always equate them to an orthotic. So orthotics that some people put into their shoes. This is a device that is inserted into the vagina that can help support organs that have been displaced or are shifting, or bulges or heaviness and pressure that people may feel. And they can be life-changing. They're a little bit cumbersome in terms of finding the right size and the right shape. And there are a couple of Canadian companies who are really innovating in this space and doing 3D printed personalized pessaries, which is really super cool.
Mm-hmm.
So pessaries are an option. Lifestyle factors. Is it dehydration that is causing your urinary urgency and frequency? Is it constipation that is contributing to your urinary urgency and frequency and prolapse symptoms? Is it posture? Is it how you are sitting and standing and the amount of movement and diversity of movement that you have throughout the day? Is it the footwear that you are wearing? Is it the history of sexual abuse or trauma in the past? Is it how much sleep or lack of sleep that you're getting? Is like, there's so many other things that we can look at from a lifestyle perspective that I hear every day, people who are put on overactive bladder medication or who are offered a sling surgery, and they still have a problem afterwards. And a lot of it is because they haven't addressed constipation, dehydration, low estrogen, bladder irritants, like all of that. That needs to be addressed. So we have the lifestyle piece in there. Then we have the pelvic floor muscle training. And this is not, you're not going to do, if you look at research, it says 3 sets of 10-second holds, Kegels done 3 times a day. Don't know many people who are going to commit to that. So compliance is very, very low. When we know also that the majority of women do them incorrectly because they've never been taught, that we're never going to get anywhere. But so we need to have a consistent pelvic floor muscle training. My approach is, let's bring it into the training that we're already doing. The yoga, the Pilates, the resistance training, the high intensity interval training. Let's bring our pelvic floor into that. Like establish a good foundation and then progressively load it like we do the rest of the body. It's a group of muscles and it needs to be trained. And we have type 1 and type 2 muscle fibers. And like, it's the same as everything else. We need to apply fitness principles to it. I mean, I can go, there's lots of other little things that we can be trying, but those I would say would be the main things: the exercise, the lifestyle, the bladder irritant types things, and pelvic floor PT and pessaries. And if you've tried all of that and you've given it a good 6 months and you've really given it a college try, you're good, consistent, still not where you want to be, interfering with the quality of your life, then you go for surgery. And at that point, all of what you have tried is your prehab. And you will now know what you're going to do as your rehab. And you're also going to know what to do as your ongoing maintenance. Because I argue it increases our need for pelvic floor muscle training afterwards.
Yeah. Yeah. So important, this conversation, because, shame hides in the darkness. But if we're talking about these things, then there's no shame to be had about it. Right.
Yeah.
I remember sitting in my car outside of my pelvic floor physio's office the first time I saw her. And I remember looking out the front window and thinking, oh my God, I'm holding up my entire life with my pelvic floor.
Mm-hmm.
And that was the first awareness I had.
Mm.
Now, I've not been through childbirth, so that, of course, maybe women experienced that earlier. However, it was just so profound, and it wasn't all that long ago, just a few years ago. And I understood the importance of taking care of that part of my body that prior to that was really quite silent until it wasn't, right? And I think that's so often the case. Okay, so let's talk about rehabbing or exercising the muscles of the pelvic floor. This is what you do. This is your Buff Muff Method, which I think is the best name of a therapy ever, ever, ever. So the more times I can say Buff Muff, let's just go there, okay? Kim, tell us, how do we get a Buff Muff?
We all deserve a Buff Muff.
Yes, we do.
So the principles, as I said, when people first come and start the program, they come in thinking it's exercise, and it is. You will get there, but I don't start there. We need to kind of lay a little bit of the groundwork of the other things that are contributing to your symptoms. That if you are chronically constipated and if you are dehydrated, I can give you all the exercise in the world. You need to address those first. So we do that, and then we get to the exercise. And a piece of what's leading up to that is also how we are holding our skeleton, the position of our pelvis throughout the day, because our posture also contributes to pelvic floor dysfunction. We have some evidence about people who lose their lumbar lordosis, so the flattening of the low back, which is usually a posteriorly tilted pelvis, it's linked to the development of pelvic organ prolapse. In many people. So we have to look at how they're holding the body and get that relationship between the diaphragm and the pelvic floor optimized. So if we were in that posteriorly tilted pelvis, sitting a lot or having a lot of pressure on the tailbone, first of all, it's going to start to ache in the SI joint and tailbones. The muscles will adapt to a shorter state, but also that breath that we need to happen, that descent and kind of widening of the diaphragm to draw air in will be compromised, given that the pelvic floor is not able to respond with the lengthening that should be happening. And the belly is also not going to be responding as well. So we don't breathe as well. And that's a whole other conversation with regards to energy levels and digestion and what have you. So we want to optimize the posture. and alignment. So that's our A. Then we want to work on the breath. So I talked about something called the core breath. That's the understanding that relationship between the diaphragm and the pelvic floor, and adding cueing to the exhale portion to voluntarily activate the pelvic floor. So things like, think of picking up a blueberry with your vagina and your anus, or think about sipping a smoothie through a straw with your vagina, or think about a tampon that is starting to slip down. We want to pull it back up. Think about pulling a partner's finger or penis deeper into us. Like, there's no best cue. It's which one resonates most with you. And so that's the B. So the A, B, alignment, breath. And then we want to coordinate. So Kegels, Dr. Arnold Kegel designed or came up with the term Kegel, and he saw his patients struggling, mostly postpartum women, struggling with activating and relaxing their pelvic floor. So he used a biofeedback device called a perineometer that helped women see when they were contracting and relaxing. And that then came into Kegels. And then again, we now have research, 3 sets of 10 seconds, 10-second holds 3 times a day is the quote unquote gold standard. But the limitation of that, I want to honor Dr. Kegel for what he did and for caring and for teaching people. But most of the symptoms and where we really need the pelvic floor to be working is not when we're lying on a treatment table or sitting in a chair or brushing our teeth or sitting at a red light in a car. We need it to perform at the gym. We need it when we are lifting a heavy bag of groceries, when we have to run to the other side of the street because the light is changing. We need the pelvic floor to be trained and performing dynamically. So we need to expand on that. And the C, the ABCs, we have alignment, we have breath, and then we have coordination. So we need to coordinate that core breath into movement. And we start with simple movements like the bridge, the pelvic tilt, a squat, or even just stand from a chair. And then we start to apply the principles of progressive overload, where we might add some resistance. We might add a little bit more dynamic, like a little bit of a jump or like explosive. Because the other piece I want to add in there too, especially for the population of your audience, we have type 1 and type 2 muscle fibers. Type 2 are the quick, like the sprinters. Type 1 are the endurance fibers. We lose more type 2 muscle fibers post-menopause. We need the type 2 to really be there when we're laughing, coughing, sneezing, doing all the things. So we need to have an element of explosiveness, of power within our fitness training. And again, we need the pelvic floor to be able to manage those loads. So doing 3 sets of 10-second hold Kegels, either at a red light or lying on your bed, is not going to train you for those explosive movements, for the heavy lifting, for the bone loading that we need. So we have to start with the basics, the ABCs, and then we progressively load from there.
Is it true that women of any age can do this program?
1,000%. My oldest is 93.
Oh, I love that. How's she doing with it?
She's awesome. She's doing great. I've had women, like literally women who have given birth to 11 children. I use that in my marketing a lot. Like, I remember her messaging. She says, I've given birth to 11 babies. And she came in, she'd been struggling for years and years and years. And she made significant change with her symptoms. She was leaking a lot. She had a lot of urgency. Waking at night to pee is also a really big win, especially for post-menopausal women who have probably been doing it for a really long time, but then they go past menopause, genitourinary syndrome comes in, and now they are waking 3, 4, 5 times a night to pee, which that's a whole other topic, is lack of sleep. But lack of sleep is also going to influence your pelvic floor function and symptoms as well.
Oh man, there's just so many different places that this touches our lives.
Yeah.
It really makes a huge impact if we've got the pelvic floor health settled. So I'm glad for this conversation. I know I heard recently that the France actually has, the French government covers all women access to pelvic floor physio. Is that right? Do you know if that's true?
Yeah, it is. It's many parts of Europe, not just France, but I would say that's the country that's most well known for it. All postpartum women are given an automatic prescription of 6 to 12 visits to a pelvic floor PT subsidized by the government. All women have access to it. So women who have not given birth still have access. They would just need to ask for the prescription for that. And like when I look at that, I think there are some people who get up in arms saying, I don't need the government and part of in my pelvic floor. And I agree with that to an extent, but taxpayer dollars are going to pay for the costs associated with pelvic floor dysfunction. So if we can, again, just be preventive minded, and if the government could make this more accessible to all, then it will save taxpayers, governments boatloads of money. It will save marriages. It will save relationships. It will reduce heart disease. It will reduce osteoporosis.
Yep.
Right.
And for sure, mental health.
Mental health for sure. Yep.
Yeah. I see it that way too, Kim. I look at that and I go, that is truly supporting 51% of the population, is to understand how important the pelvic floor is to overall health for women.
Yeah.
Thank you for this masterclass on pelvic floor health.
Thank you.
So grateful that you came with all of your creatures behind you. If for those of you that are listening to this on audio, Kim has a number of anatomical models behind her, as we talked about at the beginning of this episode. So hopefully we'll look for the episode on social media, because then you'll be able to see what we're talking about. So Kim, where can people find out more about you, and certainly about how to enroll in the Buff Muff Method?
Vaginacoach.com is my website. And I also have Buff Muff. So BuffMuff.com is where they can learn more about the method in particular. I also have the professional certification course at vaginacoach.com. Currently, that shows 2 courses. It will be updated to the new one within a month or so. And social media, all my channels are at Vagina Coach.
Amazing. About the time this episode drops, it will be mid-June, so you should be good to go for the certification.
Awesome.
So I have a final question I ask all my guests. Thank you again for coming on the show. I know this information is going to be so useful to my listeners, Kim. So thank you from the bottom of my heart for being here and delivering the goods for us. Thank you.
You're welcome. Thanks for having me.
You're my pleasure. I'll have you back. I know it. If you're willing, I'm going to have you back. We got so many more things to talk about. Okay, here's my final question for you. Actually, I've got 2. So let's talk about this government, France supporting women thing. I think this is really important, and other European countries. And we see the UK is providing hormones for women of any age, whether it's birth control pills or it's HRT for those of us in perimenopause and menopause. And here in Canada, of course, we have access to a maternity leave. And for me, I like to imagine that soon enough, we will have access to a menopause leave. So let's say our government is going to give you a stipend, a bursary of a lump sum of cash, and you get to cover whatever treatments you may wish to have or experiences you may wish to have in your menopause leave. You get to take a year off of work. You get paid whatever your regular salary is for that, or however they do the maternity leave. It's probably a standardized salary now that I think about it.
Yeah, it's a small percentage of your, it's not even a percentage of what you earn. It's a defined amount.
Ah, okay.
When I went on mat leave, now this is 20 plus years ago, it was $413 per week.
Okay. So probably wouldn't cover your groceries now. Forget anything else. Okay. Anyways, so let's imagine this menopause leave. You're given a menopause leave. You get to choose when you take it. What would you do with that time and money?
What would I do with that time and money? I would go on a retreat, with like a menopause retreat, where there was, like, in an ideal world, there would be sort of like 2 to 4, 5 gurus who are teaching about different aspects of menopause. And it would be a week-long immersive where I would learn from them and have a meeting with each one of them. So sort of a little bit individualized. I'm taking time for myself. I'm being cared for with food and a beautiful environment and escape, and, supporting all of the things that we do on retreat typically, but it would be surrounded by people that would give me the information that would save me time and money of searching and reading books. And I'm not saying there's no value in that, but there's a lot of time and effort that we have to do in self-educating. And if I could go to one place where I'm removed from the distraction of life and I could be immersed with like-minded people, but also my teachers, I would spend my money there.
I think that's a great answer. Okay, final question. Thank you for answering that, by the way.
Mhm.
It is my belief that when we start to talk about the menopause leave, we're putting it out in the field, just like the 4 minute mile, we're going to start to see it manifest. So, this is how I'm putting energy into that. And thank you for participating. So, the final question I have for you that I ask all my guests is, knowing what you know now, what would you tell your younger self?
I would I would tell my younger self to work with like create a healthcare team and not rely on one person's and no disrespect to the allopathic medical model, but I wouldn't rely just on that. I would have a healthcare team where I would get multiple opinions, and I wouldn't rely on. I was very much I could eat whatever I want. Yes, I was an active person, but it came easy. Healthy came easy to me, but I abused a lot of things under this disguise of because I was thin, I must be healthy. So I think I would want to pay more attention to the values of nourishing and honoring our bodies and having a healthcare team that would support me rather than defining my health as skinny.
Mm. And that's what we did in our generation. That's
Yeah.
what we did. That's what we
Yeah.
were taught. Kim Vopni, the Vagina Coach, thank you for joining me on the Not Your Mother's Menopause podcast.
It was my pleasure. Thank you for having me.
The information and other content provided in this show, or in any linked materials, is not intended and should not be construed as medical advice, nor is the information a substitute for professional medical expertise or treatment. We are doctors, but we aren't your doctor. Seek your doctor's opinion. If you or any other person has a medical concern, you should consult with your healthcare provider or seek other professional medical treatment. Never disregard professional medical advice or delay in seeking it because of something that you have heard in this podcast or in any linked materials. If you think you may have a medical emergency, call your doctor or emergency services immediately. The opinions and views expressed on this page and in this show have no relation to those of any academic, hospital, health practice, or other institution. Thank you.